All right, so thank you for inviting me and letting me be part of this great course. My name is Govind Panda. I'm one of the ICU doctors at Mayo Clinic in Jacksonville, Florida, with Dr. Guru. And I'm going to be talking about ultrasound for ECMO today, talking about some high yield topics and cases. So when we talk about, oh, I have no disclosures. When we talk about ultrasound for ECMO, we can talk about formal echocardiography and we can talk about point of care ultrasound. And really, when we think about what needs to be done at the bedside, it's a combination of both that we need to take into account. From the ICU standpoint, it's very important to know the basic transthoracic resuscitative views, the peristernal long and short axis, the apical four chamber, subcostal, and IVC. And then for resuscitative TEE, similarly, we want to think about the resuscitative TEs, which is our mid-esophageal four chamber, our mid-esophageal long axis, our mid-esophageal bicaval view, which is really helpful with cannula and wire placement, and our transgastric mid-papillary short axis, along with our aortic descending thoracic aorta views. So it's, to know formal echocardiography is very helpful, especially with troubleshooting ECMO. But even if you don't have formal training in echocardiography, it's very important to know these basic views and to become comfortable with them over time. So I like to break it down into pre-cannulation and cannulation help with ultrasound for ECMO, ECMO monitoring, and then weaning and after decannulation, kind of into different phases of the sick patient on ECMO. So if we start with pre-cannulation and cannulation, really, if there is time before ECMO cannulation, ideally you're able to get a formal full transthoracic echocardiogram. And the main reason for this is to really see what is your heart doing and to rule out absolute contraindications for ECMO. So if we talk about VA ECMO, we want to assess for some of the important things are to assess for the severity of if there is aortic insufficiency, severe peripheral vascular disease, dissection. These things are going to be absolute contraindications for VA ECMO. And then obviously looking at LV-RV function, ruling out tamponade, ruling out anything that would need a treatment other than ECMO to resolve the treatment. When we think about VV ECMO, we're more so thinking about biventricular function, aka the right side of the heart, and tricuspid valve disease, because this typically gets worse over time on patients who are cannulated for VV ECMO. And if there is BIV failure, then the patient very likely needs VA ECMO, not VV in that circumstance. So ideally, if you have time, get a formal full transthoracic echo. You'll get a ton of information which may be very helpful or stop you from going on a certain type of ECMO. When we think about cannulation and the vessel choice and sizes, really the biggest thing we want to do is ensure that we have full compressibility of the vein. And then we want to assess our size of our artery and vein, say if we're going on to peripheral VA ECMO. And the reason for this is because, one, we want to make sure there's no DVT, as we can see here. There's lack of compressibility. We don't always see clots in the vessels, and maybe just a lack of compressibility that gives us our diagnosis. When they're very chronic, sometimes we're able to see this organized clot like this. This general rule of thumb, the vessel diameter from anteroposterior dimensions in millimeters times 3 gives you your maximum French size of cannula that can be placed. You can also consider 3/4 of this if you want to be a little bit safer on the spectrum of that. This is more so important for the arterial diameter. The veins are usually a little more simple and easier because arterial cannulation, is not an uncommon. I mean, arterial cannulation and injury related to that is not an uncommon situation, particularly with emergent cannulation and ECPR. So let's talk about some cannulation strategies and how we use ultrasound or echocardiography to help with this. So if we talk about our classic VV bicaval, two cannulas cannulation strategy, this is our mid-esophageal bicaval view. And we can see the wire with the J loop coming in the SVC, right? We see our SVC here, our IVC up here, right atrium, and our left atrium, our intraatrial septum. And this is very important to evaluate our wire placement prior to cannula insertion so that we ensure that we're placing our cannulas in our desired position. Here's a video of wire coming in from the IVC through the right atrium going up to the SVC. And when we're placing usually our IVC cannula, we want to anchor our wire like this clearly so that we can see it go through. We want to avoid the wire going to the hepatic vein. We want to avoid it going to the intraatrial septum or down into the right ventricle through the tricuspid valve, and we want to avoid the right atrial appendage. These are kind of our hot spots to make sure our wire does not go to those places before we advance the cannula. When we think about dual lumen, single cannulation, we think about the Avalon and Crescent cannulas. We can see here our cannula looks like a railroad track going through from our SVC to our IVC. We have two drainage portions and we have our return flow, which is directed towards the tricuspid valve. If you put color on, we want to see that our flow is directed down towards the tricuspid valve and right ventricle, not up towards the intraatrial septum, which can result in a lot of issues if it is slightly malpositioned. So TE is very helpful to guide and reposition and adjust cannulas in these settings. And here's just another example of that showing color flow directed relatively down towards the tricuspid valve, which would be a reasonable um, placement of this cannula. This can also be seen on transthoracic echocardiogram or point of care echocardiogram. So here we have our four-chamber view in 2D and with color, and we can see our kind of railroad track in the right atrium in here, and we can see our return flow directed at the tricuspid valve with adequate positioning here. When we talk about peripheral VA cannulation, we're talking about usually our venous cannula being placed at the SVCRA junction or up in the SVC or down in the IVCRA junction, somewhere in this region. And this is a multi-stage drainage cannula. And then we have our arterial return, which is usually going to be in our iliacs or in our somewhere in our descending thoracic aorta. So if we look at our venous side with our mid-esophageal bicaval view, we can see our cannula coming in here from the IVC, and we see some reverberation artifact behind it. And that brings up a point. It's very important to see what's in your right atrium before putting your wires in, because if there's ICD, pacer wires, other things, you want to be very clear about what your wire is looking like. So take stock of what's in the right atrium before you put your cannulas in if you have time. On the arterial side, we want to visualize our wire in our descending thoracic aorta. And here's just an example of that. We can see our wire with some artifact around it in our descending thoracic aorta. And we typically will not be able to see the actual arterial side cannula because it's going to be a little lower down in the iliacs. And again, this can also be done on transthoracic echo. It can be harder depending on the body habitus of the patient and how the views are, but we can see here in our IVC view, subcostal, with a very dilated IVC, we could see a wire going in past the right IVC RA junction into the right atrium. And on our arterial side, we can see a wire in our descending thoracic aorta as well. And so this can be done with transthoracic if TEE is not available, as long as the patient does have some subcostal views. So let's talk about some using ultrasound for ECMO monitoring, some flows and alarms, and we'll go through some VV and VA cases. Before we talk about particular cases, it's important to remember that causes of shock in critically ill patients is going to extend to ECMO patients as well. So we don't want to forget about our general rules of thumb and our four types of shock. And ECMO patients have, another circuit and they have very particular complications, but they also will have many of the same causes that a non-ECMO critically ill patient will go through. So we want to use our point of care ultrasound to evaluate for causes of shock with our rush exam or whatever our, commonly used shock exam is with point of care ultrasound to evaluate, because these things do happen on ECMO patients just like they happen on all critically ill patients. So let's go over a few ECMO particular cases, and these are all cases that we've had in the last few years here at our hospital. So here we have a 64-year-old patient with ILD on VV ECMO, cannulated FEM drainage IJ return on day 40 with sudden hypotension. So we do a quick bedside echocardiogram, and as we can see from the parasternal long and parasternal short axis, the LV looks very thick. We look underfilled here, either severe LVH or we have severe hypovolemia in this circumstance. We see kissing papillary muscles and a completely obliterated left ventricular cavity. We look at the IVC, excuse me. IVC, we can see in our subcostal IVC long axis view, we see our cannula here, our railroad track, and we see the right atrium just off to the right here, somewhat obscured by shadowing, but we see that the IVC is completely collapsed around the cannula, right? We don't really see it. We call it like a virtual IVC. And this can be confirmed if you put color Doppler on it and you see that there's only very little flow around the cannula or none at all. This patient had an increasing abdominal size and back pain. So we did a ultrasound of their abdomen at the bedside, and we could see this complex heterogeneous fluid collection in their left upper quadrant. which ended up being bleeding. And this patient had hemorrhagic shock from a massive retroperitoneal bleed, which extended, and we were able to actually see on bedside ultrasound of the abdominal compartment. So this patient needed extensive resuscitation. And so important to remember, hemorrhage is very common on ECMO patients, especially considering they've had multiple procedures. Most of them are on anticoagulation. They have deranged coagulopathy. So it's very important to remember hemorrhage as a main cause of shock in these patients. Another case, so here we have a 36-year-old male with COVID pneumonia, patient's on VV ECMO, FEM-IJ, and got new hypotension. We do a bedside ultrasound. Patient was relatively thin. We have a pretty good view. And here we can see in the subcostal view and in the apical four-chamber view, we see a large pericardial effusion, right? And we see right atrial collapse, we see chamber collapse, and we see what looks like suspicious for tamponade physiology, right? A very large effusion. We have a little bit of a bobbling heart, and we see some chamber collapse. When we look at the IVC, we see one of our cannulas here going into the IVC-RA junction, and we see a dilated IVC here. We see some septations in the large pericardial effusion on the right of the image here as well. So this was cardiac tamponade. It needed to be drained urgently. It's important to remember patients on ECMO have cardiac tamponade. They may not have a lot of the classic signs of tamponade. And this is due to the cannulas, the RA cannula draining blood from there. So that may itself cause collapse of the right-sided chamber walls. It may decrease your CVP. You may not see mitral or tricuspid inflow variation depending on how your cannulation is. And so it can be tricky. Sometimes we only see it once the flows are decreased. When we're weaning VA ECMO, we see the hemodynamic effects of tamponade. In this case, we were able to see it pretty clearly, but it's important to have a high index of suspicion if you do suspect it. And particularly think about it after cannulation, or if cannulation was difficult, or if there was any complications. Another case here. So this is a 69-year-old male on VV ECMO, FEM-IJ again. Was placed on ECMO for massive PE. The patient improved, was extubated, and now spontaneously breathing, and now having some suction alarms. So here is their console screen, and simultaneously we did a bedside echocardiogram, and we can see their IVC view, subcostal IVC view. So we see on the console that our P venous is becoming very negative, and we can see that it's happening in somewhat of a rhythmic fashion with breathing. This patient was spontaneously breathing with pretty high work of breathing and sucking in pretty hard due to pain and agitation. And you can see that the drainage cannula is basically collapsing around the IVC, obstructing flow, increasing our P venous kind of rhythmically as the patient breathes. And so this was drainage insufficiency or cannula suction. And this is the important point about this is this can be caused by various things. We tend to have a knee-jerk reaction to this when someone has cannula suction that they need fluids. And that may be a possibility that they do need fluids, but the first thing we want to do is turn down our RPMs, turn down our speed, assess for volume status as best we can using a cardiography, using our clinical exam, everything we have at the bedside. We want to look at the position of cannula. Sometimes because cannulas may move, if the cannula comes too far out into the abdominal IVC, it may be collapsing around the IVC. Or we want to look for new causes, intra-abdominal hypertension, tension pneumo, tamponade. Other things can cause cannula insufficiency as well. So in this case, it was the patient needed more pain medication and a little bit of sedation to help with it, and this improved significantly. Our next case, we have a 67-year-old male on VV ECMO. This patient was on FEM-FEM VV ECMO, so both drainage and return cannulas were in the IVC. And the patient was on post-op day 2 after bilateral orthotopic lung transplant and developed new worsening hypoxemia. So when we look at the patient's tubing, we can see that the color looked very bright in both the drainage and return cannula. So right away, we were suspicious of what was happening. When we do a bedside echocardiogram, here's a shot of the subcostal long axis IVC view again here. If you look carefully, you can see one cannula ends right here, our drainage cannula. And if you look as we tilt through the view, you can see the other cannula actually ends right here, a little bit further up into the right atrium. And when we measure the distance between these cannulas, it was about 4 centimeters. So it was very clear that with this color on tubing of the drainage and return cannula looking very similar and very minimal space between the cannulas, that this was recirculation that was happening. And so on X-ray, we can see a little bit tough to see, but I pointed the cannulas out here on the left was before repositioning. You can see the yellow and the red. You can see the tips of the cannulas are very close together. And so what we did, the patient ended up going back to the operating room and adjusting the drainage cannula up into the SVC. And basically our color flow, our color between the two cannulas improved significantly, hypoxia improved significantly, and our recirculation fraction was significantly less. So this is a pretty typical situation that happens on these patients with VV ECMO, and the cannulas again can move around. And so it's important to think about recirculation as a cause of hypoxemia on VV ECMO. Another case, 64-year-old female on FEM-IJ-VV ECMO, day 14, now has new hypoxemia with SATs down to 80%. So we do a bedside echocardiogram, and we see the following. Here's our parasternal short axis view, and here's our apical four-chamber view. And so here we can see that we have a hyperdynamic left ventricle, and we have a normal right ventricle, and we have a hyperdynamic left ventricle as seen here on the four-chamber view as well. We estimate the patient's cardiac output using LVOT diameter and LVOT VTI using pulse wave Doppler through the LVOT in the apical 5 or 3-chamber view. And here we can see the diameters too, and the LVOT VTI is quite high, 33, normal being around 18 to 22. And generally speaking, when ECMO flow to cardiac output ratio is greater than 60%, we're able to achieve adequate oxygenation in a SAT, usually greater than 90%. And here we can see our ECMO flow is 3.8 liters. So if we use these numbers to estimate our cardiac output using the volume of cylinder equation, then we get our native cardiac output is almost 10 liters. So this was basically a case of high shunt fraction due to elevated intrinsic cardiac output on VV ECMO. And this is also a particular cause of hypoxemia on patients on VV ECMO. A lot of these patients are typically, if they do have a distributive shock type of profile, they do have a normal heart, and they may have a normal or high cardiac output. If they start becoming tachycardic, fevers, or developing new sepsis, it's pretty common that we see the cardiac output go up, and often we do see hypoxemia. Now, what do we do about that? We can try to increase our ECMO flows to try to increase our ECMO to flow to cardiac output fraction as best we can. We can try to optimize our vent settings as best we can. We typically don't use beta blockers much anymore because we don't want to decrease our oxygen delivery by decreasing our cardiac output. So we try our best to optimize our ECMO flows as much as the patient can tolerate and look more at oxygen delivery. Just a note, cardiac output can be estimated with echocardiography like this pretty well. The studies show that our LVOT VTI and calculating our cardiac output do correlate pretty well with right heart cath studies in a lot of patient populations, but it is dependent on expertise and the type of imaging, the imaging quality you're able to get. And that is variable from patient to patient, as we all know on ICU patients. Another case, so we'll move to VA ECMO now. A patient on peripheral VA ECMO, femoral vein to femoral artery, now has new worsening hypoxemia and decreased pulsatility. So if we look at their right radial arterial line here, we can see that there's very little pulsatility. We do a bedside echocardiogram, and we can see here, so this is our parasternal long axis view and our apical four-chamber view that we're showing here. So as you can see, we have a severely dilated left ventricle, one of the reasons the patient was in cardiogenic shock and placed on VA ECMO. We can see that we have a lack of aortic valve opening if you look closely here. And we see severe smoke or spontaneous echo contrast in the left ventricle with very poor or no ejection at all. We see the same thing here on our apical four-chamber view. Using DEFINITY or ultrasound enhancing agent, echo contrast, we can see more clearly the contrast just staying in the left ventricle, circulating around there because of very poor cardiac function. When we look at lung ultrasound, we saw in this patient bilateral diffuse B lines, consistent in this case with pulmonary edema. So what's going on here? We basically have LV distension and a lack of LV ejection. Pretty classic scenario on peripheral VA ECMO, particularly FEM VA ECMO. And so what's happening is if you look on the left here, our retrograde flow from our return cannula is going to increase our afterload on our heart. If this goes unchecked, the LV will distend. We can increase our mitral regurgitation, cause increased left atrial filling pressures and backflow and causing pulmonary edema, loss of ejection, loss of pulsatility, severe stasis in the LV. And in some cases, this can cause clot to build up in the aortic root, aortic valve, and in the LV. And so what can be done? We typically think about unloading criteria when we want to think about how do we unload this left ventricle. And there are various strategies to this, and definitely we want to think about it when we start seeing some of these clinical and echocardiographic signs. Unloading methods, there are many. It's something, one that we typically use quite a bit these days is the Impella, or a microaxial flow pump that we can put into the left ventricle. And so there are various Impellas available. And so at least in the United States, the typical ones that we have now are the Impella CP and the Impella 5.5. The 5.5 requires a surgical cut down and can be placed in the axillary artery. The CP can be placed percutaneously. And it's important with Impellas, with them becoming more frequently used, that we're able to see them clearly on echocardiography and identify our inlet area, so that we know the inlet area on the CP. We want the mid inlet area, which is the mid of this dropout area, to be about 3.5 centimeters from the aortic valve annulus. And with the 5.5, we want it's usually a little deeper. It does not have a pigtail, as you can see that the CP does. It's usually about 5 centimeters from the aortic valve to the middle of the inlet. We don't want it to be deep into the walls or the septum, and we don't want it to be too far out. And so this requires frequent echocardiography to ensure that Impella positioning is adequate. So let's talk quickly about weaning and post-ECMO. So we'll talk more or so about weaning VA ECMO, because that requires a lot more echocardiographic monitoring compared to VV. So what we want to do here is, when the patient is under ECMO flow, we're not able to clearly see how our native heart is going to respond. So by decreasing ECMO flow, or doing a wean down trial or a ramp down trial, then we're able to reload the heart. We're going to decrease our afterload from our retrograde ECMO flow, and we're going to increase the preload back to the right and left heart. So now we can assess our native cardiac function under more real conditions, now that we've decreased our ECMO flow, to try to make an assessment how they would look off ECMO. So some of the parameters that have been studied is LVEF greater than 20 to 25%, LVOT-VTI, surrogate of our stroke volume and cardiac output, greater than 10 to 12 centimeters, and our lateral mitral valve annulus peak systolic velocity greater than 6 meters per second, which is the velocity of this tissue actually that we're measured with tissue Doppler. And this is at a VA ECMO flow of about 1 to 1.5 liters, so a reduced flow to assess the native heart function and these parameters. These patients who met these criteria were much more likely to successfully wean off ECMO. Tissue Doppler parameters as well, we always want to think about the right ventricle as well. So we think about our TAPC and our RV function and our FAC. If we can do 3D RVF, we can also eyeball the right ventricle. This is our S prime, looking at our tissue Doppler of our lateral tricuspid annulus. Our linear measures like TAPC and S prime have limitations. Ideally, we're able to look at area or volume measurements if we can, like fractional area of change. In reality, a lot of the time we're assessing this somewhat with eyeballing, and it's important to compare to prior echoes to see how the improvement is at various flows. So here's just an example of a ramp down study. We went from an already low flow of 2 liters per minute to an ECMO flow of 1 liter per minute. And here we can see on the left, we see a low ejection fraction, somewhat decreased RV function. When we decrease our ECMO flow, now we've decreased our afterload in our heart, and we've increased our preload to our heart. So we can actually see an improved ejection fraction. We see maybe a little bit of improved RV function. And if we look down here, we can see our LVOT-VTI was 11, and that went up to 15. So that, using that as a surrogate of our stroke volume, we can see that our function improved and our stroke volume also improved somewhat. This patient was successfully cannulated in that case. Post-decannulation, very common to have thrombotic complications, as I'm sure everybody knows. So we want to have some protocol and frequency to assessing for DVT in these patients. And here we see the same picture from earlier with lack of compressibility, and you can see a large thrombus. And here we see on the right side, this is from a case that there's a cast of an old cannula left in the IVC. So the patient actually was decannulated here, but thrombosis is very common because of all the foreign objects and material that were in the patient. And so a lot of times these patients need ongoing anticoagulation, and this has to be, the risks and benefits of this have to be weighed. So in summary, ultrasound plays a key role in the safe delivery in ECMO, and it is recommended in the ELSO guidelines to use during these phases, all the phases of ECMO care. And that's a combination of formal transthoracic echo, point of care ultrasound, real-time dynamic ultrasound guidance for cannulation, and decannulation strategies, along with using TE guidance if you have availability of that with providers who have TE expertise to assess for complications. I like to think about it in three phases so that kind of keep it separate in your head, and use ultrasound as much as we can on these very sick patients in the ICU. And that's the rest. That's my talk. Thank you.